Good morning. I'm Chris O'Keezy, the 2024 president of the ACHE chapter. I am delighted and honored to be here. I would like to welcome each and every one of you to our second quarter breakfast meeting. It is really great, as we say in Texas, to see y'all. And for those of you online, thank you also for joining us this morning. This time, we'd like to have our reflection, and I would like to introduce the chapter board member, Stephen Foster, market president for St. Luke's, to give us our reflection this morning. Stephen?
Mention it to me.
Good morning. All right, let's center ourselves for our reflection, please. I recently had the privilege of taking my family to Washington, D.C. I had not seen or been there since I was a child myself. I was rediscovering it along with my wife and children. I was particularly impressed with the Vietnam Veterans Wall. For those that have seen this before, please indulge me for a moment. See, when you visit the Vietnam Veterans Memorial, you descend a pathway at the base of two black granite walls inscribed with the names of more than 58,000 American service people who died in that war. That's just one of many wars, right? So the two walls form a kind of broad V, like wings, that one points south towards the Lincoln Memorial, the other northward, almost directly at the Washington Monument. The memorial is set into the earth as you walk from either direction. The height of the wall increases along the number of the names. It is quite simply a place of deep devotion and heart-rendering reflection for those who enter. As you descend the path about halfway, the city around you begins to disappear. Only small trees remain visible to the north and the very top of the Capitol building beyond the Washington Monument. It feels as though you are submerged in a vast rural field, and while from the depths you can see the Capitol dome, anyone on the Capitol steps would not be able to see you. You and those on the wall would be invisible to them, their view from one monument to another monument uninterrupted. Anyone willing to venture down the pathway cannot remain untouched, because when you are in this submerged state, it is as if you are surrounded by all those fallen heroes. There is a silence even though people are around you. There are many monuments across Washington, and the nation reminding us that freedom has a very real human cost. I believe monuments and memorials aren't meant to stand silently. They are meant to be interacted with, touched, walked along, and interpreted. On Memorial Day, we honor people who have died while serving in the armed forces of our nation. How do we honor those who gave their lives in our wars? Yes, by building monuments, by holding memorial services all over the country, and by decorating their graves with flowers, wreaths, or American flags. This is all very important. However, this Memorial Day, I suggest we do something in addition to those activities. I say we start in our homes or in our work, even in this room, by honoring these fallen heroes in our daily commitment towards everlasting peace and social justice for all. Let us all bow our heads in a moment of silence and invite you to join me in an earnest and heartfelt prayer for the end of all wars on earth. And let's conclude our reflection by the following well-known but not well-practiced quote: "Let there be peace on earth, and let it begin with me." Amen. Thank you.
Thank you very much, Stephen. Thank you. At this time, we'd like to recognize our first-time visit. Those visiting with us for the first time, please stand. And for those of you online, please wave. Any first-time visitors with us? Thank you for coming. We hope you will join us for more of our amazing and upcoming events in 2024, including the annual Leadership Conference in November 7th and 8th of this year. At this time, I'd like to recognize new ACHE members. We would like to welcome those who have become new members of ACHE since the last quarterly breakfast in December 2023. Please stand, and those online, please wave. Any new members that just joined? Okay, it's good to know all of us have been members here. Thank you for your decision to become a member. For those of you that are online or may not be here today, ACHE is a 50,000 member across the nation. We finished 2023 with almost 1,800 members in this chapter alone. So again, very notable. We are officially the third largest chapter in our nation. So again, kudos to you all. This year, we have an audacious goal, a goal to become 2,000 strong. So we cannot achieve this goal without all of your help. And I hope each and every one of you will help us spread the word, recruit new members, so that we can become at 2,000 the largest chapter in the nation. It is audacious, but very achievable. So again, we need your help to help us achieve this target and goal. Special thanks to our strategic partners whose contributions at various levels have made it possible for this chapter to provide outstanding programs to its membership and scholarships to health administration graduate students. We are very thankful for your support of all the dedicated partners. Our chapter corporate members, St. Luke's, HCA, Houston Methodist, MD Anderson Cancer Center, Memorial Hermann Health System, and Texas Children's Hospital. We thank you for your partnership. Our platinum sponsors, Lean Task. We have our gold sponsors also, UTMB Health, Intercontinental Houston Medical Center, and our silver sponsors, Abbott Nutrition, Harris Health, HKS, Jackson Physician Search, Legacy Community Health, Lumineer, Page, Realty Trust. Thank you for clapping. Texas A&M Public Health, Texas Women's University, University of Houston Clear Lake, Village Medical, and EEPB. We also have our bronze sponsors, Brazos Sport College, Candio Partners, Kindred Healthcare, UT Health, School of Public Health. Can you please give them a round of applause? I want to recognize two organizations for their sponsorship of today's important panel on workplace violence, Khmer and Aramark. Thank you for supporting this vital discussion on a hot topic that really touches every one of us in our organizations. That has fortunately impacted so many of our facilities, our staff, our patients, as well as our visitors and community. So thank you, Khmer, for sponsoring this. Thank you, Aramark. A round of applause, please. I stand here on the shoulders of volunteers that make this organization what it is today. Our past presidents, some of who are here today, Noel Cardenas, Sandy, thank you. And also our board members. For all of our board members that are here today, please stand so we can recognize you. We also have board observers, undergraduate student, Kerry Shook. Is Kerry here? Kerry? No? Okay. I want to thank our foundation board, who without their partnership and sponsorship, we would also not be a very viable chapter. And I'd like to thank President Todd Cleaver. Thank you, Todd. Secretary and Treasurer Mark Phelps. Board members Gina Brumberg, Ann Claire, Jack Berkeley, and Don Wagner. Thank you all for your support and your service to this wonderful chapter. I want to thank our community members and leaders. We have 11 vibrant and very active committees in this chapter. Chapter awards, community service and philanthropy, diversity, equity and inclusion and belonging, education and events, marketing and communication, member advancement, membership and retention, mentorship, networking and relations, student membership and involvement, strategic partnership, and sponsorship. Will all of our community chairs and committee members please stand so we can recognize you? And for those of you online, please wave. We are currently looking for additional committee volunteers and community leaders. Please contact our chapter administrator, Mark Biscone, for more information on joining one of these committees and getting involved in this chapter. We are eagerly awaiting your call. Now, I'd like to invite Danny Freeman to the podium to say a few words on the importance of becoming board certified in healthcare management, the ACHE credential, and the exam review course our chapter has developed. Danny?
Good morning. Thank you so much for letting me have a couple minutes of your time today. My name is Danny Freeman, and I've been a member of the ACHE since 2017. And I received my board certification and became a fellow in 2023, nearly a year ago today. Thank you. Guess what? I have an assignment for you. I have the privilege this morning of talking to you about becoming board certified in healthcare management through the American College of Healthcare Executives. Excuse me, the FACHE credential is the premier credential that distinguishes healthcare leaders. Excuse me. Becoming a fellow demonstrates that you have prioritized adding value to your role as a leader in healthcare. And you have invested and put forth both the work and effort to demonstrate your competency in all areas of healthcare management. It signifies your understanding in the importance of education, improvement, civic service, and continued growth in all healthcare areas and roles. This prestigious certification and the journey to it opens doors of opportunity, creates foundations of lasting relationships through networking, and will immediately provide you with a sense of pride knowing that you prioritize this for yourself. The Southeast Texas chapter provides numerous opportunities to support you in your professional development journey in obtaining your board certification. The Membership Advancement Committee, chaired by Mr. Cole Kalita and myself, are here to serve and provide resources with you every step of the way. One of these resources we're most proud of is the Board of Governors exam review course, which I personally have taken and can attest to its efficacy in helping me pass this exam. The review course is a 10-week-long course held virtually covering each section of the exam. The course provides exclusive access to experienced healthcare leaders and executives serving as the faculty. Each class is interactive and led by a subject matter expert who can provide relevant and pertinent context on the topics that you'll see on this exam. Additionally, each session is recorded and distributed to attendees after the course for further preparation and study. You receive 2 practice exams with answer keys. And once you pass and take the exam, you can reach out to our local chapter to receive a $50 credit. I know you were also always looking for qualifying education, and the Board of Governors exam review course is actually worth 12 credits. This evening will be our 7th of 10 session into our spring semester with over 40 participants. And it's been very active and very well received, and we're already looking forward to the fall semester. If you're not yet at the stage for your FACHE journey where you're ready to sit for the exam. Cole, myself, I saw Mark, or any of the other fellows that are in this room, would be happy to discuss the individual value that we personally and professionally have benefited from and what your next steps are to support you in your journey to fellow. I'd love to chat with you after our meeting concludes this morning to answer any questions you have in pursuing your FACHE. And if nothing else, I'd love to meet you and confirm to you that you have somebody in your corner. I'm so sorry. And people in this room excited to see you succeed. In closing, I'd love to challenge you this morning to invest in your next step in your membership of the American College of Healthcare Executives. It's attainable and you can do this. You already put forth the work and effort in your everyday obligations as healthcare leaders in providing improvement, mastery of core healthcare areas of knowledge, and contributing to best patient outcomes. Thank you so much for letting me have your time this morning. My next step is to get a glass of water. Thank you so much.
Let's please get a cup of water, please. And now I would like to invite Hannah Snyder and Daniela Martin de Campo to the podium to say a few words on the 2024 Sporting Clays Tournament and Scholarship Fundraiser, which was a fantastic event. Hannah and Daniela.
All right.
Good morning, everyone. I'm Hunter Snyder, the current operations manager at Hamilton Health Bucks and the current chair for the ACHE-SETC Strategic Partnerships and Sponsorships Committee.
Good morning, everyone. My name is Daniela Martin Del Campo. I'm a project manager for Houston Methodist Cypress Hospital, and I'm also the co-chair for our Community Service and Philanthropy Committee. And just over 2 weeks ago, we held our third annual Sporting Clay and Scholarship Fundraiser. And last year, we raised almost $20,000 in support of our scholarship programs.
And we're happy to report that with your support, we were able to raise just under $23,000 this year. Additionally, we'd like to thank our incredible sponsors for the event, CompleteRx, Excite Realty Group, Houston Methodist Willowbrook Hospital, Texas A&M University, Texas Children's Hospital, The Woodlands, Realty Trust Group, Memorial Hermann Southwest, Enteric PSI, Encompass Health Katy, Millis Development and Construction, and Heidelberg Materials.
And the list continues as sponsors. Thank you so much. We had Don Wagner, Todd Kaliva, Anne Claire France, Noel Cardenas, Lori Blackwell, Armstrong Flooring, ONQ, Baptist Hospitals of Southeast Texas, St. Luke's Health, Universal Surgical Assistance, Alvin Community College, and Brazosport College. Thank you so much for your sponsors. We would not be able to hold this event without our sponsors and the volunteers who help organize and lead our event. We'd like to give a huge thank you to Rick Burnett and Mark Biscone for their incredible leadership for this event. And thank you to the Community Service and Philanthropy Committee members, as well as our Strategic Partnership and Sponsorship Committee. Please save the date for our 4th annual Sporting Clay event, which will take place April 18th, 2025 at the Greater Houston Sports Club. So you can go ahead and mark your calendars. We hope to see all of y'all there for a great day outside at the range. Thank you so much.
Thank you again for your hard work. This event was very successful, and we thank them for the tremendous amount of hours and effort that they put in to actually facilitate and host this event. At this time, I'd like to congratulate 6 chapter members that have recently advanced to fellow. These are starting with Gary E. Bevan, Is Gary here? Lou Butler? James Hearn? Peyton LaBeau? Francis Monroe? Carrie Rice? She's online. Awesome. Again, we want to thank them for, again, completing just what Danny mentioned. Again, it is a recognition that you are committed to this profession. If there are any new 2024 fellows that are present that I did not mention, please stand and wave your hand. No? Okay, thank you. Additionally, I would like to mention that we have 34 chapter members that are exam authorized, which means they can take the exam whenever they're ready. And another 372 that are eligible for advancement, which means they can apply to take the exam. So we encourage you to please take your ACHE to the next level and work on earning this fellow as soon as possible. If you pass the exam before the end of 2024, you can attend the convocation ceremony at the 2025 ACHE Congress, which is going to be held here in Houston, which means that you can bring your family and, you know, all the people that have supported you in the endeavor. So we please encourage you to make every effort for those of you that are exam authorized and those of you that are eligible for advancement to make it a point to do this exam this year so you can be part of that. We'll be there to cheer you on. And it is a ceremony that it is a very dignified ceremony that really, really recognizes the efforts that you've made to achieve this notable mark in your careers. ACHE has a recognition program that celebrates members' commitment to healthcare management profession. There are 3 award levels, which are the Service Award, Distinguished Service Award, and the Exemplary Service Award. These awards are based on a range of specific volunteer activities, both at the local and the national level, that demonstrate leadership, furthering professional excellence. For those of you who have been affiliated or work with any organization, particularly ACHE, you would know that this organization would not be possible, would not be viable, would not be what it is today without our volunteers. So this is a very notable award. And at first, I would like to to honor today Kumba Lewis. Is Kumba here? Come on up, Kumba. For the ACHE Service Award, we would like to recognize Kumba for all your volunteer and achievement. Oh, we're supposed to look over here. Oh. Thank you. Congratulations. It's thank you. Tim is here. Yeah. All right. Speaking of ACHE National, this chapter was honored with 3 awards this year in March. We were awarded Higher Education Network Award, the HAN Award, through Brazosport College. Any representatives from Brazosport College? Let's give them a round of applause, please. They were recognized for the best undergraduate program and ACHE partnership. We also awarded, this chapter was also awarded chapter distinction for meeting 2 or 4 metrics set by ACHE National, an award for sustained performance, as we have met at least 1 or 4 metrics 3 consecutive years. We are only one of 7 chapters in all of ACHE to be awarded the award of chapter distinction among 76 chapters. So this is a very, very impressive recognition by National. Now I'd like to invite Frank Tortorella, our regent, for the region award. Frank?
Thank you so much. Good morning, everybody. I'm thrilled to be here. And I am so excited to be presenting an award today. So someone in this room is going to be getting an award. Who is it? Someone, and it is a Senior Careerist Award. And drum roll, can I have Anne Claire France come up to the podium?
Thank you. Oh my, something for the shelf? Thank you very much.
Congratulations, Anne. Well deserved. Thank you, Frank. Also, at this time, I am deeply honored to recognize the 2023 Board Member of the Year Award. This award was created for an exemplary ACHE-SETC board member, a board member that exhibits excellence, a board member that others look to emulate. The Board Member of the Year goes to the 2022 Board of Directors who offered thoughtful perspective in times of need, helped to drive more involvement from the organization, not only attended their committee meetings as the assigned board liaison, but also participated in planning and execution of their awards. Our inaugural Board Member of the Year goes to no other than Dr. Tim Holland. Thank you for that round of applause. Also, if you don't know, Tim is going to be the 2025 president of this chapter. So he's the incoming president of the chapter. And I'm honored to be a part of his team and his leadership next year. There are important chapter announcements. I'm going to pause for a minute, but I want to make sure that you all know that this chapter has so many offerings for our members. Coming up next week, June 6th, we'll be hosting our second annual leadership quorum event with GHS HRM. Come join us for a discussion on the realities and challenges facing the healthcare industry, featuring experts from the greater Houston area and beyond. We also have our third annual mini conference in August 22nd. So join us for this event also with the Texas Women's University about a commitment to excellence and embracing different backgrounds in healthcare. Finally, we also have our 2024 Leadership Conference, November 7th and 8th of this year. So save that date. Again, it is I would say, more economically cheaper, less expensive way to get your face-to-face credit. So again, we want to encourage you to seize this opportunity for, again, advancing your career and getting those credits. So stay tuned. We have a lot of other events coming, but we look forward to seeing you at these upcoming events. And now, for what we all came here for, I am honored to introduce our own board member, Mr. Eric Allum, and our esteemed panelists, to please come up for a very vibrant discussion on workplace violence. So, and Eric will introduce our panelists. Eric?
All right, good morning and welcome. We're a little bit behind schedule and I don't want to take away from the important content that we have in our esteemed panel. So I'm going to kick this off here quickly, and then I'm going to allow our panelists to give a little introduction to themselves. Their full bios are on the site, so please, I encourage you to go and look at that. But starting right here, I'd like to welcome Dr. Ronald Paulus. Next is Gail Donovan, thank you, and Andrea Mazzucchelli. Close? Thank you. All right. Ron, will you go ahead and start with a quick introduction and we'll get started.
Sure. Thanks for having us here today. This is a topic that's really near and dear to my heart. I came to this passion or evangelical journey when I was the CEO of a Mission Health System in Western North Carolina. And I was doing nurse focus groups, which I did from time to time, in addition to quality rounds and those kinds of things. And in back-to-back sessions, I had a different nurse say to me, when I asked my catch-all question at the end, what else is on your mind that we haven't talked about? And they said, we don't always feel safe. And I was like, oh my gosh, like I knew, right? I'm a physician by training. My wife's pretty clear, you're not a real doctor anymore, don't touch the kids. But I've had my own personal experiences with being trapped in a room with an angry patient, an angry family member, and the door is inaccessible to me. But I never thought about it that way. And it sort of created this journey that I've been on since about 2014, when people really weren't talking about this. And I think this is one of the most impactful things that as leaders, we have the responsibility to keep our patients and team members safe. And so I'm an ex-health system CEO and ex-physician, according to my wife, although I still think I am. And I'm currently the CEO of an advanced care at home company, Maribel Health, but this is still my passion.
Thank you, Ron, and thanks, Eric. We really are excited to be here with you today because, as Ron indicated, we share a common passion as former health system executives in senior leadership roles. My personal background, I'm Gail Donovan. My personal background was as a chief operating officer and president of a large health system for over 30 years in New York City, and also spent some time in the Midwest as well in a similar role at a regional health system. And as Ron indicated, frankly, workplace violence, unless it was a really egregious incident that happened, never came to the C-suite attention for many, many years. And only as we frankly experienced incredible rises along during the COVID pandemic, did we start to increase the conversation and discussion. So our opportunity today to share with you what we have learned, and thankfully the developing best practices that are available for all of you as leaders and other colleagues across the country, is a responsibility that we feel very personally to give back essentially as our service opportunity to the communities we serve. So thanks for having us today. We're looking forward to the conversation.
Good morning, Andrea Mazzucchelli. I serve on the panel first and foremost as a professional nurse. My professional background has been as a chief nurse and quality executive for academics and Catholic healthcare systems nationally. But first and foremost, I knew that My last year as Assistant Chief Nursing Quality Officer, I learned that one of the top 3 self-reported safety events was about workplace violence. It opened my eyes and my ears, and much like Ron, we went on a listening tour about what was really happening. Professionally, it is an impact on what is keeping and attracting the best and brightest men and women to join a profession that I love, one of which I know that our own well-being influences the level of confidence and compassionate and competent care that we can deliver. So I hope we've heard that this is not a shy group. And so we're going to do our best to engage you in conversation. And I welcome the dialogue and your insights and the work that Texas has done in helping lead our country in mitigating and reducing workplace violence. So thank you.
All right, there is no easy way to ease into this topic, so we're just going to jump right in. As experienced healthcare leaders, we know that workplace violence is not a new reality in healthcare. Why is now the time that healthcare organizations in Texas must address this epidemic?
Well, I would say now's not the time. It's past time, right? This is something that has been going on far too long. You know, the statistics, 5 times more likely than any other industry to be experience workplace violence. 92% of all healthcare workers experienced it during 1 month alone. During the time of this webinar, 2 nurses will have experienced healthcare violence, right? Our fundamental responsibility as leaders, as I just said earlier, is to keep our patients and team members safe. And the irony is that everybody thinks of it as either a regulatory requirement, and you have the new, law here in Texas, but that's not the reason. The reason is because A, it's the right thing to do, and B, it's the right business decision. Because investments in workplace violence mitigation and elimination show up in the bottom line.
I'd like to just also say that we have the time now to break the cycle of violence. Verbal and physical violence has become accepted for years, an accepted part of many people's jobs in healthcare, especially nurses, but not exclusively nurses. So we can break this cycle. As Ron said, it's the right thing to do. Now's the opportunity to do that. Thankfully, there's incentives now for us to really focus on this and best practices that are evolving. But still, a statistic that still holds true over the last couple of years, only 70% of, not only, 70% of incidents of workplace violence are not reported and not known. So a culture of safety, as we take pride in our cultures of safety for patients, and Ron's going to talk a little bit more about this in particular, needs to be extended to our staff members in a very deep and enriching way.
Yeah, I guess I just add to that, and we'll hopefully talk more about it and bring to light. It's not only extended to, but many of you have spent the last several years on the safety and reliability journey. If we're not looking at workplace violence as a cornerstone of our safety and reliability journey, then we're missing a foundation. And what's emerging now is the relationship of employee engagement and patient outcomes. So more and more empirically, we're beginning to understand the impact of what a safe staff and a staff that believes they're working in a safe culture can do in terms of their own level of engagement and their ability to fulfill their obligation. And as a leader, for us to fulfill our professional obligation.
Thank you. I know early in my career, we focused a lot on doing no harm to the patient, but it certainly has seemed now a new conversation has evolved is do no harm to our staff, our providers, and our nurses. So it definitely has changed. This question is for each of the panel members. We are all trying different things. Can you share with us some best practices that you've seen?
Yeah, I'm going to build upon your comment about do no harm. When I had that experience at Mission in North Carolina with the nurses saying they didn't feel safe, I was like, what do I do? How do I get started? And I had spent most of my career focused on quality improvement and quality optimization and efficiency optimization. And everybody here probably remembers, even the really young faces in the room, the To Err Is Human report in 1999. That was a bombshell, right? We kill 100,000 people in the healthcare system. It's one of the major leading causes of death, et cetera, et cetera. And it took a really long time, but it provides a step-by-step guide and roadmap to how to address this exact same problem. I recently wrote a paper in the ACHE-SETC Security Journal comparing the quality improvement movement to the staff safety movement. And what did they do? They first galvanized a broad sense of crisis, that there's something here that we really have to do something about. They began to measure what was happening with respect to safety events. At Mission, we created a very tangible categorical score for unwanted verbal contact, verbal assault, unwanted physical touching, physical assault with injury, and physical assault with injury and time lost from work. And we integrated that directly into our safety reporting system so that it was another activity. What else happened in the safety movement? We realized that it was a systems failure and not a person failure. We provided training, and we know that de-escalation training and trauma-informed care training are the single most important features that we could do. But we did other things too. We deployed technology, order entry, drug-drug interaction testing, bedside barcode administration, right? There are now technologies that enable people to keep themselves safe, including silent duress alarms and other kinds of critical features. So it's a multifaceted approach, but if you go back to the origin of the quality and safety movement, if you follow those exact same steps, encourage reporting, do the training, deploy the technology, you can make a very, very significant impact.
And the American College has suggested in their guidance very, very similar, yes, identical steps, as has the Joint Commission. So those of you that are in organizations that are accredited by Joint Commission know these standards were put in place, new standards, in 2022. And the Joint Commission is surveying against these standards. And I imagine the college, in part, took advice from those standards. Hopefully we'll see more from OSHA as well, which is pending. Yeah, we have been waiting for OSHA to really weigh in and update their advice. But there are actual steps to follow and best practices. Start by defining workplace violence. You know, it's not the physical assault only, it's the verbal altercations that take just as much of a toll on the well-being, mental health, and frankly, the retention of our workforce. What is one of the number one issues in this country is limitations of our workforce in healthcare. People are not going into different professions. Andrea mentioned this about nursing, but it's across the board. Chris, you told us last night how difficult it is at Harris Health just to recruit housekeeping employees to positions. And what we can talk with you about is that these steps that can be taken to actually improve the culture of safety, including a technology solution and set of solutions, can be extended to every single team member and not only nurses. And it's affordable. We'll come back to that point in a moment. Do you want to add to this?
I think I just add to the point about how you use the framework for our quality and safety journey is much like this. So when you're having safety huddles, being able to ask and talk about, did anyone feel unsafe last night? Did you find yourself in an uncomfortable situation with a patient or a family? Let's talk about it. Same with what happens on our own leadership rounds as we go and engage our staff. And Chris, you talked about this last night, the ability for us as leaders to role model culturally and transformationally what it means for our staff to feel comfortable about raising their issues of concern and discomfort. That opens the door. And people will see and feel that in an organization very quickly.
Just like to add one other point. Just like in the patient safety movement, if we're not measuring and we're not measuring effectively and reporting on the measurements, your multidisciplinary workplace violence committee, which hopefully you all are in the process of either establishing or iterating on that type of approach, should not only be multidisciplinary, but also multi-levels in the organization. Put some of your frontline team members on that committee to really bring a sense of personal awareness to what is happening in their worlds. And in addition to that measurement, we now have the duty and responsibility to report on those measurements all the way up to the boards of directors of our hospitals and health systems. Because similar to patient safety, our boards need to know what's happening with our workforce in order for us to be feeling a level of support and engagement from all levels, top down, bottom up, and across all different disciplines.
Thank you for touching on outcomes data. I think that's an important topic, and I'd like to come back to that and ask Andrea for a follow-up on that. But I also heard, I'm glad you mentioned the duress alarms, because I think we all know that we're going to have to leverage technology and innovation in combating this. So I was wondering if you could give us any practical advice on best practices for evaluating the types of duress alerting technology or technology in this space in general to complement a holistic workplace violence prevention program.
I'm going to jump in first here. I mean, first, you need to be able to notify others in a discreet way. You know, it's very tense when you're in a situation where the verbal indications are rising, and we all know it, right? We can feel on the back of our neck the tension levels are rising. That's when you should be able to identify and initiate a discreet alert. We also know that alerting security can often take quite some time for security members to come into a situation. They may be located in a very remote location of your campus, whether it's a hospital or ambulatory campus. So proximate alerting is crucial. So not only when the staff member who could discreetly put their hand up underneath their ID badge and press essentially an individual personable, wearable panic button. That's how you should think about it. And we teach staff to put it underneath their ID badge so that they can do it discreetly. And then that proximate alert can go to any team member that is also badged in the immediate area. Not only nurses, but the food service worker that's delivering trays to a unit, or the housekeeper that has come in to do the evening cleaning. That training that can be provided to those staff members to actually stick their head in the room and just say, oh, Mary, can I see you about something? Sometimes that simple interruption is enough to de-escalate, in addition to what the individual staff member themselves is trying to do. And we actually teach use of early and often alerting. Early in an escalating situation is going to help de-escalation and avoid the incident and avoid injury. What would you add?
Well, yeah, I think that was well covered. I'll share a story where I, screwed something up and led to something good. So I was involved in the development and creation of one of the duress alerting technology solutions that's now called Come Your Strong Line. I created it at admission with another company for a totally different use case, which was to monitor the location of our physicians in our critical access hospitals. Because on the cost report, you can report physician downtime, but when we did time and motion studies, we always had different numbers. And so we worried about compliance. And so we co-created this idea of a low energy Bluetooth solution that can know where someone is and track them. And we basically said, if they're physically in the ED or if they're charting, then that's uptime. Otherwise it's downtime. Okay. I was clueless that this thing was actually the equivalent of this personal panic button. And having the combination, the intersection, which is the double down that I want to do, of a panic button plus the de-escalation training, the de-escalation and trauma-informed care training. If you go back to the beginning, what do you do from a security overview and implementation perspective? One, you start with the physical environment. You look at all of your entry points and access points. Two is you look for high-risk areas, weighted furniture in the ED and behavioral health units, and that kind of thing. Three, you have behavioral emergency response teams. These are the things that we did at Mission. Four is the de-escalation and trauma-informed care training. Five, if you can do it, it's a very powerful thing working with the community to create community crisis destabilization centers. So you decant a lot of that behavioral health activity from the ED if you can. But the last line of defense is this personal duress alarm, plus the de-escalation from nearby proximate colleagues.
Thank you very much. I do want to go back to the outcomes. And Andrea, I'd like to get your thoughts on, what are some of the positive outcomes that you're seeing in hospitals that were early adopters or have taken an aggressive approach to dealing with this?
So I think some of the earliest empirical evidence that we've seen, and many of you perhaps have seen the Press-Ganey Safety Report 2024. If you haven't, I'd encourage you to connect the dots from your conversation about workplace violence and culture of safety. But one of the most telling things is that when staff report positively a safe environment, they are reporting on the culture of safety. The engagement of the staff in those facilities is ranking at the 98th percentile. When staff are reporting and rating the culture of the safety environment low, their percentile ranking, give a guess, 2 percentile. That's the difference in terms of what it means. And I think there are a couple of things. So that's probably the single biggest new release outcome. Nursing hat, obviously, there is a real correlation studied most directly in emergency departments of intent to leave. And an interesting point, not only of the nurses that have been directly involved in an event, but nurses who have been witnessed and observed an event. So the recovery of what happens to staff after not only themselves being involved, but having witnessed it and the disruption that it causes in the patient care environment is significant. The two outcomes from a patient perspective that we're seeing has to do with falls, not a surprise. I'm uncomfortable about how close to be with you and how often I might trigger an event and miss care. I think aside from that, we obviously see retention, workforce, patient outcomes, lost days of work, reduction in injury because de-escalation leads to situations early and often rather than a reactive kind of response. But colleagues might have other things to add to the outcomes.
Thank you. So as healthcare leaders, we're often in that struggle of balancing margin and mission. And, we know this is important and we need to address it. But there's obviously going to be barriers, financial being one of them. In my own organization, we recognize that having full names on badges was putting a lot of our caregivers at risk because they were getting bullied socially online and all that. And so even just the cost, we looked at that, thought that would be a simple thing to reprint 10,000 badges was very concerning. So with that, I'd like to ask, what barriers have you seen and what recommendations do you have for our leaders here to overcome those?
Thanks so much for that question, because I know that everybody in this room, most of you, are struggling economically at your organizations, and there's never a new nickel, so to speak, for new investments, and you have to find ways to offset new costs. Well, the good news here is that by you investing in supporting your team members to feel that real sense of safety in their environment, there's going to be a financial return on investment that you will undoubtedly experience. We're seeing that in hospitals that we're working with and supporting across the country. What does that look like? It looks, and you referenced this, and Ron, you did as well. When staff are engaged, they're going to stay in their positions. You're going to see a reduction in turnover. You know, we saw a huge spike, right, in turnover during COVID, and it started to come down a smidgen, but turnover stats are still very high. The average RN turnover in this country is 18.4%. And the cost to turn over one position is $56,000 on average. And there's a huge range for that. You know, in certain communities, it's over $100,000 and over 100 days to fill a single RN position. A 1% change in turnover, 1% plus or minus on average is equated to $262,000 plus on an annual basis. Think about what you could do with $262,000 in your organization. It is really at the point that we can't afford as leaders to not invest in improving the safety of our team members. So when we help counsel, I worked mostly in safety net hospitals and some critical access hospitals in the systems that I've worked in, and trying to create the business plan and the business model associated with new investments was no small feat. So I work directly with leaders like yourself to build those business models, to anticipate and then track your return on investment that you will experience. It will retain your staff longer. It will help you recruit because you're setting a bar that is a high expectation and standard. Actually, part of our conversation last night was pretty interesting, understanding that new younger generations are coming in to interview for jobs saying, what are you doing about workplace violence? I want to come to a job that's going to guarantee my safety. Very different, right, than what we've seen accepted by older generations. So help break the cycle. Engage by looking at recruitment, retention opportunities, as well as the post-incident effects. So there are treatment costs associated with, unfortunately, our team members that are injured. And also even just exposure to verbal incidents, they're going to take more time off from work. And these are studied, referenceable things that occur. Your staff that are challenged with these exposures, either personally or witnessed, will take more time off from work. And you have to fill that position on your schedules. It's going to cost you more money. We still have an unprecedented high level of use of agency staff, not just nurses, but particularly nurses. The average cost of an hour of an agency staff in this country is now $85, and it ranges up to $200 if you're filling a critical care position. So we can build the business models and you will experience a positive ROI.
Just briefly, you know, in LA, it's $250 plus free housing, agency nursing. So
Wow.
yeah, good you're in Houston. I just, let's be honest. We're going to look back on what we didn't do, just like we look back on the patient safety movement and say it took 14 years from to err is human to get a critical mass moving. This is a no-brainer. It shows up in your staff. It shows up in your retention. It shows up in your bottom line.
Thank you both. What resonated with me is I think we often hear in meetings or we start meetings with, can we afford to do this? And I think to your point is we should be asking the question, can we afford not to do this? All right. The panel has told me they are very excited to engage. They want to rapid fire questions. And so let's go. Mark, you're going to signal me or because I'll keep going.
Appreciate your perspective on this important topic. I'm curious, as the ecosystem of healthcare is changing, we see more and more partners involved in the footprint of delivery. We see more contracted workers involved, and we see more home care delivery of care. For my part, my wife's a home healthcare nurse practitioner, and the number of times she walks into a house with machine guns on the floor, with doors locked behind her, with physical threats, verbal threats, is just unbelievable. So I'm just wondering, in this world where the extent of the healthcare system is going beyond the physical walls of a particular entity and the employees that are in that entity, how do you continue to help drive safety through that distributed system?
Great question. With the ability to support technology development, cloud-based solutions, one of the additional capabilities and features of this personal badge that we're speaking about today is that there will be a home care application, whether it's a nurse like your wife or acute care at home that's occurring. There will be different work streams that will need to be identified for that, because the alerting is not going to go to a central security dispatch alone. It needs to also go to local police authorities who can potentially respond even quicker to these individual situations. But the capacity and capability technically is there through Bluetooth and Wi-Fi access. And we'll be pleased to be rolling that out really in a very short period of time. That's the newest capabilities, and it builds upon not only in location alerting, but also parking garages, open parking spaces, if you have parking lots and so on, because oftentimes incidents can occur in lots of different locations.
I think the other thing that's happening that clients and interested parties are thinking about is that persona that we build through AI and through tracking, trending, and monitoring the events that have happened. You begin to see patterns of words and behaviors and actions, and those are building an at-risk model. So hopefully there will come a time in which, by diagnosis and perhaps other kinds of things, your wife and others that enter into more perhaps unsecure locations will be able to say, these are the 5 attributes we see in this clinical situation. We're suggesting 2 people go for the first 30 minutes. And this is the next level of assessment. Or, gee, we want to make sure a behavioral health person is coming with the clinical person. So we think we're going to get smarter every time that we think, and to the earlier point, but we have to know and understand it. We have to be willing to pull back the onion and examine those kinds of situations so that we can understand the science behind it. And I've seen some organizations be really crafty now at trying to design and develop those kinds of at-risk models.
Yeah, I'll just add, I think the technology is awesome and it's going to keep getting better. But as I mentioned, my day job is running a company that partners with health systems to do hospital at home and other advanced care at home activities. So this is near and dear to my heart. And the reality is that the real line of defense is the training of that individual and the authority of the individual to de-escalate themselves out of the situation, including leaving after they enter or not entering at all, because it's a continuum of risk. And although I do believe that we'll get better in terms of predictive analytics and the other features, even if and when that happens, there's an undeniable delay time between when any escalation can happen and when any intervention can happen beyond that individual person. But just like we did when I was a health system CEO in the day, we would flag patients' records who had exhibited prior violence. And if there were any techniques that were useful with respect to de-escalation, we've got to build out the entire tool set for that individual. But at the end of the day, it's the training and the authority to make their own personal decision.
Yeah, hi. Again, want to thank the panel. And my question is kind of related. maybe on a more practical sense. So you think of it as a continuum, right? Dr. Polish, you mentioned there was injury. I was out of work on one end, but on this other end is this rudeness. It is the profanity. It is just, the sort of anger that's in these patient rooms. Plus, you mentioned safety net hospitals and mental health. I've got this patient here for 5, 7, 8 days. They have a medical condition, but they're suffering from mental health issues. They are yelling at nurses, not just every once in a while, like the whole time. How do you draw, as leaders, how do you draw limits? How do you better protect your staff? How do you, and Andrea, nurses are like, oh yeah, that's Mr. So-and-so, and they're still going in and they're still dealing with this individual. And yet it is disruptive, and over time, it begins to wear you down. How do you boost them up when it maybe isn't on a path to violence, but it's just constant belligerent rudeness, yelling, tenseness?
Yeah, I'll start. I'm sure you'll have a lot to add. I think you have to start with, let's separate out behavioral health for a second and start with the general rank and file and the expectation of a zero tolerance policy. And this gets back into the training of the workforce, right? To say, if you're being spoken to in an inappropriate manner, and remember in the categorization model that we created, which I'm not arguing is the best, but it was just one, unwanted verbal contact, right, was the first level of violence. And so training about how to communicate with the individual and say, Mr. Jones, I appreciate that you're upset, but we don't have that kind of discussion, that dialogue here. We have to speak with one another civilly, or we can't have this conversation, right? And having the ability for others to come into the room to double down on that, and including being willing to prevent family members from being in the room if they're the ones that are engaging in this kind of behavior. So it's gotta start with clear lines that are appropriate. And then those do have to be modified for behavioral health patients and those with mental illness. But normally that can be facilitated by the fact that we have different kinds of staff there. We have more staff. They have a different kind of training. And then we deploy other things that we hope not to use, at the far end of the spectrum, restraints, but at the earlier end of the spectrum, behavioral health specialists and technicians that are constantly involved. But the continuum needs to be matched with the experience that's occurring. And it's that training.
There's no single solution. It's multifactorial, right? So in addition to the training and really that zero tolerance, and there's lots of ways that is being manifest now, with signs very visible and public, in addition to part of the admission packets, information about the zero tolerance policy, but really putting teeth to it. So how is leadership going to support, we actually would administratively discharge patients when situations were not able to be accommodated. And those are very hard decisions to make, right? Because people need the care and at some level want the care, but are not accepting of how that potentially that interaction is occurring. So that's a leadership challenge. But in addition to really looking at zero tolerance, one of the components on the spectrum of a full plan, frankly, is teaching early de-escalation and support. I can tell you, we have all seen frontline workers feel such a sense of empowerment when they wear a personal badge, that they know that they can help themselves as well as their team members be safer in their environment. So it is a wide spectrum, no single answer.
And just sorry, one last thing. And I want to emphasize this training is not a learning management system module. It's not a PowerPoint that somebody's scrolling through to check off. I did my, Joint Commission testing. This is simulation-based training, where they are exposed to an actor patient, an actor family that are escalating, and then they have to be available to de-escalate. I also mentioned the behavioral emergency response team, right? It directly parallels the rapid response team that we did for medical emergencies and escalation. And anybody can call that, just like anybody can call that rapid response team. So it's building out, starts with the zero tolerance, it then is extended by the training, and then it's supported by additional infrastructure.
I think the only other thing that I'd add, there are two parts. One is the ability for leadership to give nurses the choice about what and how and what day they are confident and competent to go in to care for those patients makes a world of difference. So nurses' ability to say, can't do it today, is not a sign of weakness or vulnerability. It is an accepted response. And we know that there are different levels of resilience of individuals every single day. We've all experienced it. And that control is so critical. I think the other thing is it requires leadership. It requires structure and process. As a professional nurse, it also means you don't send the biggest, meanest nurse in to take care of that patient. I'll show him. So in the training and de-escalation, there's some unlearning that as professionals we need to do because the therapeutic exchange is different. The skills are different. It's not a reactive response. And I think sometimes we aren't as skilled as we could or should be in knowing the new way in which. So it's not the person who's going to put more controls and be more demanding of perhaps that individual or family. There's a new way and a therapeutic way. It won't always get to the right answer. But I think there are things that as professionals, we need to admit that we need to learn differently.
And I want to point out in your purple bags, there's a very thoughtful white paper talking about this issue. And then we've handed out, thanks to our Texas Hospital Association regional executive, a toolkit from THA that they put together, because we're here also in part because of two laws that were passed in the last legislative session, SB 240 and SB 840. But one of the things that's great in this toolkit is an example of posting in this change for penalties for assaulting in your institution. So I encourage you to make a version of this and post it and, start really educating your staff and patients and family members about that. Do you guys want to talk really briefly about SB 240 particularly? We have that one slide next.
Please go. You'd like to just. Yeah.
I'll take it. A significant win for all healthcare workers occurred in May of 2023. So here in Texas, this was an important passing of a Senate Bill 240, SB 240, mandating all healthcare facilities in Texas must adopt workplace violence preventions by September 1st, 2024. So we are all on the clock. And we're all working towards this, but just kind of a quick highlight here. It must provide a comprehensive violence prevention plan, must encourage healthcare workers to report incidents of violence. It must conduct annual workplace violence prevention training, adopt a system to quickly respond to and investigate violence, and just patient care assignments based on the needs and safety of employees. Harold.
Thank you. Harold Griffin with Alvin Community College. One thing we've not really addressed yet is the workplace incivility, because we're seeing some increases in workplace incivility, which also to me is a safety concern. So can y'all address how you're addressing that particular issue?
Just for clarity, are you referencing between coworkers?
Yes.
Yeah, okay. At least what we did and what we've been seeing is applying the exact same standards. that a zero tolerance policy for that kind of incivility, the ability for someone to escalate, right? And to know that leadership is going to have the backs of those that do. It's not easy, right? Because there's always he said, she said, that kind of thing. But just like there was with patient safety, whenever we began to acknowledge that errors existed, we empowered even the lowest level employee, quote unquote, to be able to stop the line, so to speak. You need to have really clear lines that say we do not enable this within our organization, and have others who witness this have the compulsion to step in and intervene and to facilitate, just like they would facilitate a de-escalation with a patient.
Yeah, if we're required to report all incidences, it's going to be a lot of reporting.
It is. And remember, we started out with patient safety incidents that were almost zero. And now they happen every single day in every single hospital in America, right? 70% don't get reported. So it's a step. If I might make one final comment, I would just look inside your heart and your brain together and ask yourself whether this isn't a critical thing that something must be done about. And make a commitment to yourself that this isn't just an ACHE breakfast with great awards and a pride and influence that you all have, but you're going to go out there and you're going to actually do something. And you're going to do it not just because the SB 240 says you have to, but because A, you know it's the right thing, and B, you know it's going to generate a return for your organization. Like I said at the very beginning, it's not time, it's past time. We have to take action. This is our responsibility. And every single person can make an impact to keep the next person from having to experience what others already have.
Thank you so much for having us. Oh, is there time for one more question?
Is there time for one more question?
Okay, sure.
Just maybe a question, just if you could share your experiences. We've talked about half of the equation, about training and empowerment of our teams. The other half of the equation is the patients. What's your experience of empowering and informing the patients of those zero tolerance? What are the rules?
I think it's, again, we've seen organizations, and we talked a little bit last night. Massachusetts is actually sending some communication to patients and families about expectations of behavior, about what and how. I'm not sure if I'm getting to what you're looking for, but there are also therapeutics that allow patients and families to respond to their own reactions and response very differently. But there are organizations and indeed states that are now setting and writing about the behaviors and expectations of performance that an organization, a particular physician practice, is going to expect, and the consequences if that isn't fulfilled.
Yeah, and Gail mentioned previously, some organizations are putting large signs on the walls saying that, this is a civil environment. We don't allow for aggressive discussion, et cetera, et cetera. It can be part of an admission pack. I don't give much credence to the packs. Nobody reads them, but it can be part of the admission experience with a nurse or with other caregivers saying, this is how we do things here. Our culture is one of civility. So it is a two-sided equation, and we're increasingly seeing expectation setting with the patient and family members, frankly, because it's unless it's a behavioral health patient, at least in my experience, it's more often family members than it is even the patient. And so it is a dual-sided coin.
Oh, it also, he talked about incivility between patients and families are perceptive of that. So how I, as a patient or family, watch how that team interacts with each other is a cue for me as well. So any level of tolerance and acceptance in a culture about those kinds of things, I think needs to be evaluated.
My question just kind of piggybacks off of his. We've made tremendous strides in patient safety, but I think why we kind of haven't made even more is because of the inclusion of the patients and the families in on the investigations, in on the RCAs. With the same aspect is why not include them in on the workplace safety committees, getting their vantage point. So have you seen that being done in hospitals and other organizations? And do you think that that would be beneficial?
Go for it.
Yeah.
Honestly, we haven't seen that in any significant way yet at all, but I think that would be a great leaning practice.
And there are existing patient and family advisory councils it would be perfect. And as I was learning more about Texas, I mean, you have a research grant that is studying that helps fund the innovations. That I think would be a wonderful submission to the grant to say, gee, let's talk about how empowering patients and families about this through patient advisory for inclusion in workplace violence. That's a great idea.
Gold star to you. I have seen it in a RCA example, but I have not seen it on a workplace violence committee. And that is a darn good idea.
Thanks for some just terrific information. I'd like to just ask you all about daily leadership practice when it comes to this. You talked about trauma-informed care and the de-escalation training and leadership commitment to all that. But what are those daily leadership practices that, other than, for example, making sure that asking folks about, anything about being uncomfortable, but what are those those things that employees can observe about their leaders every day to see that their environment, that leadership is really committed to having a more safe environment?
And thanks for the question. And I think in some ways we've been trying to touch on the leadership responsibilities in all of what we've been talking about today, but leadership is often about modeling, right? And providing that safe encouragement to report, to actually know that there's real teeth to RCAs as it relates to WPV, and that it's not just another committee meeting, that your actions are really supported in your rounding, and you include questions in your purposeful rounding about feelings of safety. You do appropriate and detailed measurement, evaluation, and reporting back. So similar to what we do to look at engagement by work unit, do it for WPV incidents and bring that information back to the team members so you can improve outcomes. You can improve not only the level of engagement and conversation, but the outcomes for your staff well-being as well as for patients.
Oh, one final comment. There's an MIT professor, Edgar Schein, who talks about leadership. And what he talks about is that team members pay attention to what animates leaders, to what they measure, to what they promote, and what they reward. And so in addition to the sort of embedding into daily operations, morning huddles, quality rounds, nurse reports, sign out, all of those things need to get hardwired, but so do the effector arms back of rewards for people who identified these things and intervened. Escalations and animations from leaders about how important this is. So it's the bottom up, it's the top down.
I just add, strikes me that early on, the notion is don't go out and find what someone did wrong. I mean, we're looking at how we delivered the best care that could be heard. So having a situation, so being able to recognize that the inquiry of a leader is about building better systems, not about finding the people who are involved in the situation. So there are still a lot of nurses who bleed. If I would have been more patient, if I would have been more gentle, if I would have been more therapeutic, perhaps the escalation wouldn't have happened. So our ability as a leader to turn that conversation around to a science that's about building the right structures and processes and systems.
On behalf of the Southeast Texas chapter and everybody in this room, I want to thank our panel for coming and sharing their expertise.
Yes. Thank you so much.
Thank you.
Good job, So I hope this session was insightful and informative to each and every one of you. Workplace violence is real. It is something that we all are challenged with. And I picked up quite a few nuggets today from this really conversation. I like panels, you get to really interact. And so I want to thank Eric, Andrea, Gail, and Ron for this very stellar, spectacular, and awesome session. Just a reminder to keep an eye on upcoming events at our website. We also have mailing list as well as LinkedIn group and Instagram. So make sure you join us at upcoming events and opportunities. And I want to, again, use this opportunity to let you know that I'm deeply honored to serve in this capacity for this chapter. And I want to thank each and every volunteer that serve in different capacities. You are what makes this work. And again, please go out and have a wonderful week. And for those of you that were impacted by the inclement weather that we had, I hope you are recovering well. And let's help each other recover and prepare for the next one. It's the start of hurricane season, June 1st. So more to come. I hope we are braced and ready for it. Okay. Thank you all very much.